Welcome, everyone. Today, Benzo Warrior Community is excited to welcome Dr. Mark Leeds to speak to our Zoom roundtable. Dr. Leeds will present for about an hour, and then we'll entertain our questions afterwards. His talk is entitled Decoding Bind, Patient-Responsive Approaches to Navigating Benzodiazepine-Induced Neurological Dysfunction Management. Dr. Leeds is an osteopathic physician with a focus on medication-assisted treatment for opioid addiction and alcoholism. In addition to practicing medicine, he's host of the Benzodiazepine Podcast on Apple Podcasts, as well as the Rehab podcast on the Mental Health News Radio Network. Dr. Leeds provides concierge private benzodiazepine withdrawal services, and he serves on the medical advisory board of the Benzodiazepine Information Coalition. Dr. Leeds, thank you for agreeing to speak to our group today.
Yeah, thank you. I'll just start with a little brief disclaimer that, I'm going to be talking about some different medical therapies, and some of them may be unproven, speculative, and, I'm not recommending any kind of medical treatment to anyone. So, be aware that this is all for informational purposes, and it's not to be taken as medical advice or recommendations for anybody. Some of these things are hypothetical. Some of these things, medications or treatments may have not been used or studied at this point, but just to stimulate thought and discussion, but not to be taken as effective or safe interventions. And of course, talk to your doctor or medical professional about, you can discuss these things and go further with that. So who am I, and why would I be talking here today about benzodiazepine-induced neurological dysfunction, or BIND? So my name is Mark Leeds, and I'm a person who has a blog and a podcast. I'm not a researcher. I'm not a scientist. I don't have a lab full of assistants who are researching benzodiazepine injuries to the brain. I wish I did have a lab, but it's me, and I like to write speculative blog posts on different topics and explore ideas and interview guests on the podcast, and which is a lot of fun. And the main podcast that I have is called The Rehab, which is on the Mental Health News Radio Network. And that podcast was originally focused on medical addiction treatment. About a year and a half ago, I interviewed the filmmakers for the documentary Medicating Normal, which was an interview that had nothing at all to do with addiction. So I think that was one of my first non-addiction podcasts. It was about drug dependency, drug tapering, iatrogenic injury, and the problem with a lack of informed consent from doctors, and about the risk of taking psychiatric medications. And from that point on, I included more interviews related to benzodiazepine injury. So now the podcast is about more than just addiction-related topics. And then I started also a separate podcast named the Benzodiazepine Podcast. And the main purpose is to isolate interviews that are related specifically to benzodiazepine injury, and treatments, different kinds of treatments that might work, or that we've speculated, or treatments that do work or helping people. But if you do look at those two different podcasts, you'll see that a lot of the interviews that are on the Benzodiazepine Podcast are also on the Rehab podcast. I think to start, it's important. We cannot emphasize enough that benzodiazepine physical dependence, benzo physical dependence, is not addiction. And I know you've probably heard that repeated over and over again. Everybody, in this group, we know that. But I think it's important to reinforce it, because I've even heard doctors who work with patients with benzodiazepine tapering and withdrawal and protracted withdrawal. I've even heard other doctors who should know better calling it a physical addiction. And I don't think the word addiction should be used at all. As a physical dependence, not an addiction. Addiction to benzodiazepines is very rare. Well below 1%. There are people that abuse benzodiazepines, and they may use them addictively. They may use them with other drugs. Like you probably have heard, people who use cocaine or methamphetamine will take Xanax to come down, and Xanax is known to be the most common secondary drug of overdose death, which means that it didn't cause the death at all, had nothing to do with it. It just happened to be the number 2 drug found in their system. So of course that gives it a bad reputation, and there's a lot of misunderstanding But the misuse of a drug doesn't make the drug addictive. Addiction is a condition that's characterized by cravings or obsession over the drug. They have the 5 C's of addiction, but the main ones are craving or obsession and compulsive use in spite of self-harm. So, a person who's addicted to a prescription drug is not going to take it as directed. A person who's taken, for example, clonazepam 0.5 milligrams at bedtime for 20 years straight, they're not addicted because if they were, they would have been taking the whole prescription probably in the first day they got it. So addiction and physical dependence are 2 very different things. And of course, there's a lot of confusion over that topic with doctors, unfortunately, family members, friends, loved ones who believe that their loved one is addicted and not physically dependent. There's a lot of confusion over that, which of course leads to gaslighting and, sending people on, off to rehab and detox and things that cause even more problems and psych wards and things like that. Rehabs and detox facilities that are geared to help people get off an addictive drug, such as opioids, alcohol, cocaine, or methamphetamine, they do advertise heavily to attract people who are what they say, people who are addicted to benzodiazepines. So in a way, they're preying on people and family members and loved ones who've made the mistake of thinking that physical dependence and withdrawal are addiction, which they're not. So, that's and one of the most important things when I do a consultation with someone or I start working with a patient is, I think the most valuable thing to say, especially when the family members are in on a call, is to say, please don't send them to rehab, don't send them to detox. If you were thinking about that, that's the most important thing, because that's going to cause much more severe problems when a person goes to a detox and they taper them in whatever, 5 days, 7 days, 10 days, 2 weeks, or a month even. So other than me being someone with a podcast and a blog, I'm also an osteopathic physician. I've been practicing since 1999. I did residency from 96 to 99. Before medical school, I majored in math in college. Originally planned to go into software engineering. Plans changed along the way, and very happy with that. I remember one of my math professors telling us a story about a mathematician who had come up with an important medical model, and he met with doctors and researchers, medical researchers, and no one would take him seriously because he wasn't a doctor. So this mathematician decided to go to medical school to become a doctor, only for the purpose of having his work taken seriously by the medical community. I think it's important that we don't make that mistake, that we learn, are able to listen to people who are not doctors, especially when it comes to bind. And it's important to not have this outlook that the doctors are the only authority. I've learned the most from people in the community, people on forums, people who I've met online, who have taught me a lot about concepts of benzodiazepine withdrawal, the idea of what is toxic encephalopathy, and it seems like bind is in a way a subset of that. Tapering off of a drug in a safe way. Of course, we learn from the Ashton Manual. That's a great starting place. But going from there, and that should be the first place that a doctor starts in learning. And that was where I first started. A patient came in my office for an unrelated issue, and they said, "By the way, have you ever heard of the Ashton Manual?" And I could have said, "I'm really tired. I only have 10 minutes with you. Thank you for that. I'll forget it as soon as I walk out the room." But fortunately, I didn't do that. I, thought, wow, that's an interesting thing. And of course, that's a great thing about having a blog, is that you're always looking for new topics. You're always looking for a new thing to write about. So yeah, I was definitely interested when I heard a new term I hadn't heard before. The idea of tapering, speaking of math, I mean, that Dr. Mark Horowitz, who was on this, had a lecture on this platform. I watched his lecture a couple of times. Very incredible, very interesting. The idea of the taper following that hyperbolic curve, and I think I'm going to talk about that in a few minutes. But it's very similar to tapering with, we treat people with opioid addiction, and we treat them with buprenorphine. Which is a way of tapering somebody off of an opioid when they're addicted to it. We switch them to a substance where they still have a dependence, but they're not thinking addictively. and they can cut back little by little, and much better than cutting a person off cold turkey. There's a lot of parallel issues with cutting a person off of whether it's alcohol, opioids, or any kind of drug that has a physical dependence issue. But with buprenorphine, we find that the patients report back, in the beginning, we say we start them at 16 milligrams, and they quickly jump down from like 16, 14, 12, 10, 8. And then they get to 8, and going down from there is a little harder. And we don't have to like really set the curve for them ahead of time, because they tell us, I can't do it. Going from 8 to 6, I'm just not going to do it. So we're like, okay, let's go to 7.5 or 7. So it's patient directed, and that's how tapering should always be. It should always be patient directed. The patient tells us how they're feeling. It should never be me saying, let's stick on schedule. This is our goal. We're trying to taper you off in 5 months or 2 years or whatever it is. If the patient is not tolerating it, we have to respond to that and go a little bit slower or differently, or stay at a certain level for a while. But there are a lot of parallels with addiction treatment and also treating pure drug dependence, like with benzodiazepines, where there's no addiction involved at all. So during my residency, I remember there was a lot of drugs that were released on the market. In the clinic, the outpatient clinic, we had these drug reps coming in all the time. And I remember that being within a very short period of time, certain drugs came out in the market and then quickly were withdrawn by the FDA within a short time due to some serious adverse event. I thought that was an unusual period of time, that was just happening more than ever. And I was curious, I looked it up. There was a lot more drugs withdrawn quickly than I was even aware of. The studies that they do to get these drugs approved by the FDA are pretty small. I remember seeing a study for one drug, like where they had it said N equals 31 patients, 31 people to get a drug approved to be used on, hundreds of thousands or millions of people. There was one drug, Direct. It was an anti-inflammatory, and it was going to revolutionize pain management. The drug rep came in with these really fancy, colorful pamphlets. And, if you've never seen it, how drug reps present things to doctors. I mean, they really make it digestible and attractive. And, so Direct, they had this beautiful color graph showing one Direct tablet is equal to 2 Percocets. We've done away with the need for opioids for pain. Now all you need is Direct, an anti-inflammatory. And, it sounded great to us. And we got samples, and the residents, we tried it for headaches and toothaches and stuff like that. And then it was withdrawn from the market for causing liver failure. And the drug rep came in yelling at us saying, I told all of you you weren't supposed to prescribe this for more than 10 days. And he had never said that. But I guess he was probably told to come in and say, I told you all that, and you did it anyway. But importantly in that message was that we probably all should have read the literature a little bit better, because it probably did say it in the fine print in the prescribing information. But yeah, so Direct, that, and that happened a lot. That same drug rep, we used to like seeing him. He used to bring in food and pens and notepads and stuff and all kinds of little gifts for us. And his other product he had was Premarin and Prempro, the hormone for menopause. And I at one point discovered, I was just reading about it, and I saw that they derived that from horse urine. And I'm like, how is that there's a pill with horse urine in it? Is that even possible from a major pharmaceutical company? So I confronted the guy about it, and all he just said back to me, he said, well, those horses are treated very well and humanely treated. And I was like in disbelief. I'm like, that wasn't really my issue. I'm sure they're treated well. I didn't realize there was actually a major medication. And Premarin or Prempro was one of the most prescribed drugs during the 80s. It was like top of the list, like 1 or 2, like right up there with Prozac. So, and one of the studies he showed us was about how Premarin works on premenopausal monkeys. And those are the kind of studies we would see from drug reps. Look, and he got excited. The title of the study was something about premenopausal monkeys. I'm like, how does this apply to human beings? And there's another funny story about that there was a meeting we went to, and this was during the period when they were cutting back on gifts to doctors. They weren't taking doctors on skiing trips and baseball games and all that stuff anymore. They weren't even giving us pens or notepads. But they had figured out a way to pay all of us $250 to show up to this lecture on a blood pressure medication. And the way they did that was they said, we're helping with market research. We're helping them to develop their marketing pitch for doctors in the future. And so we're all sitting there to a fancy dinner and everything. And this guy is giving a lecture. And one slide pointed out how this one blood pressure medication would work very effectively for isolated systolic hypertension. You know, when the top number of your blood pressure is high and the lower number is normal. And so he went through that slide really quickly. And then he got to the next slide, and one of the doctors raised his hand and he said, go back to that slide before. So he went back and he said, did you just show us a slide that showed a study of 4 rats? So he based that entire premise of isolated systolic hypertension on a study that they did on 4 rats, you know, not even humans, and not even a bunch of rats, but just 4 of them. And so yeah, we could have walked out of that lecture thinking, oh, this drug is great for isolated systolic hypertension, you know, not even realizing that it was based on completely nothing. So yeah, so anyway, yeah, so in that time, that was in the late 90s, and a lot of medications were coming out. I remember also, along with Premarin, like I said, Prozac was one of the most prescribed drugs in America. I think that might have been number 1. It was definitely up there at the top of the list. And if you look that up, you'll see Prozac was at its peak in the 90s. Everybody was taking it, or probably almost everybody. And when antidepressants, the SSRIs, the selective serotonin reuptake inhibitors, were prescribed, the psychiatrist or primary care doctor, because we were marketed that we could prescribe SSRIs, you know, like regular primary family doctors, that it was safe. They wouldn't interact with anything else. We didn't have to worry about, you know, what is an MOI inhibitor, whatever, you know, all these things that we have to worry about with drug interaction. Like the old ones, the tricyclic antidepressants and all these other older ones were scary for family doctors. You know, like we didn't really know what can we do safely. Like, do we have to give them dietary restrictions, or don't take this drug or that drug? But no, the SSRIs, like these are like safe. You know, the drugs they're promoting almost seem like colored Legos. Like these all fit together really well, and you don't have to worry about it. So yeah, things like Prozac, Paxil, Zoloft, we were taught these are safe. You can take them and stop taking them anytime. Never tapering or withdrawal was never mentioned ever. And of course, those drugs take 2 to 4 weeks to work. I mean, assuming that they work at all. But so during that time, it was common for a psychiatrist or a primary care doctor to prescribe a benzodiazepine if you were taking for anxiety. You know, for depression, it would be different. But you know, these drugs were also used for anxiety. I think Prozac would be off-label, but I think maybe Zoloft and Paxil were FDA approved for anxiety. So you know, if somebody was having a panic attacks and anxiety, and they went into the psychiatrist, they would say, like, well, here's something for your anxiety, but during the next couple of weeks, you know, while you're suffering with anxiety still because the thing won't work, here's a benzo. You know, here's you know, psychiatrists always loved clonazepam or Klonopin. That was always their favorite. It might still be, for all I know, but anyway, so although it does seem like most of the patients I see that's like seems to be the number 1 drug, you know, maybe lorazepam the second. So a patient would get their Klonopin and take that for 2 weeks, and you know, waiting for the Prozac or Paxil or Zoloft to kick in. And you know, when it didn't, another couple of weeks, and they see the doctor a month later, and like, well, can I get more of this Klonopin? Well, no, because that was only to cover you until the other one took over. Well, but this is working really well. And, you know, the doctors only have, like, you know, like I said, 10, 15 minutes. They have to jump to the next room. And the easiest way to get out of a patient room is to write another prescription. So there's another month of medication. And that could, you know, easily lead to decades. You know, maybe the patient goes back to their primary care doctor and says, look, I've been taking this for 3 months. The psychiatrist was fine with it. Can you continue that for me? And, you know, what one thing leads to another, and a patient ends up being on a benzodiazepine that should have only lasted for 2 weeks at most, for, in some cases, years or decades, you know, 10, 20, 30 years. And, you know, because of benzodiazepines, they, as you probably know, they do work pretty well for treating anxiety, at least in the beginning. And the SSRIs, you know, are really probably not all that great for anxiety, even though they got approved for it. You know, and, you know, when you think about that, and that, I think I wrote about that later, but that's something I'll talk about now, that why is it different? Somebody's addicted, somebody's using, say, Xanax addictively, they're taking a huge amount of Xanax and going through their whole month of Xanax in a day and probably doctor shopping. How is it that person can go to a detox, but it's not a good idea for a person who's taken their Klonopin for 20 years as directed at a low dose? Why do they have to worry about tapering over a long period of time? Because of the damage caused by a low dose over a long period of time is worse than what happens when someone binges on a benzo for what was probably a relatively short time. And I was thinking, and this was in the middle of the night, I was thinking of an analogy, like it's kind of like if you're trying to cut a hole in a slab of concrete using a pressure washer, turning up the power as high as you want, you won't be able to cut a hole through it. But, look at the Grand Canyon. Over millions of years, the little Colorado River caused all that damage digging this deep canyon. And so, yeah, long periods of time, a low dose of a benzo causes a lot of damage. It's cumulative over long periods. Although it is true a person could take a benzodiazepine and have problems even if they took it only for a short time. Anything can happen, really. And if you wonder what happens to people who are addicted, why is it so easy for them? They can just get detox quickly. It's not necessarily so easy for them. They're just more blamed for what, their disease, or whatever, their addiction. Addiction isn't even really a medical term. It's more of a layperson term that, because the Alcoholics Anonymous 12-step program is so heavily entrenched in medicine and addiction medicine, that the people are told, well, it's not really your fault. Your addiction is not your fault. But then again, it is your fault, because the 12 steps talk about your defects of character and shortcomings and making amends and praying and meditating and so that particular medical condition, unlike anything else, we treat with prayer, but everything else gets medical treatment. So it is. A person could be addicted and binging on a benzo and they're addicted, or they could be binging on alcohol or opioids and they go to a program that cuts them off cold turkey, and they may have long-term problems, but because it's an addiction, people might not consider it the same thing. But and I'll get to that in a little bit. What I kind of call the my tapering theory, kind of my unified tapering theory. Maybe tapering isn't just for benzodiazepines and antidepressants. So let me see. So so as far as the fact that the pharmaceutical company doesn't talk about tapering, and they don't teach us in medical school, there's nothing at all about if someone does take Prozac or Klonopin for a long period of time, or maybe even a short period of time, that they should be tapered gradually. And by tapering doesn't mean go from 20 milligrams of Prozac to 10 to 5 and you're done in a week, but it maybe needs to be done more gradually. And then the doctor who hears about it says, well, how do I do that? You didn't give us enough dosage levels. You didn't give us enough, maybe we needed 1 milligram increments or a liquid form for every drug that you have, something that makes tapering possible. And that's something that occurred to me, that I always think of tapering as like landing an airplane, and it does kind of follow that curve, the Dr. Horowitz's curve of, the worst way to land an airplane is to go straight down, if you were told, like, the pilot passed out, you have to pilot the airplane and you sit down on the seat, I think any of us would know, even if we have known nothing about landing an airplane, we're not going to say, okay, let's go straight down and get down as fast as we can. Because that's like, the biggest disaster is going to happen if you do that. We also know that we don't want to go down on a straight line. That's pretty much just as bad as going straight down. That landing an airplane is, a curve, just like that same curve, maybe even not quite as steep in the beginning, but in an emergency landing, the first thing you want to do is to get out of the clouds and down quickly. And so maybe in a taper, you might start out faster. Like I had mentioned with buprenorphine, people can tolerate, and I think it's the same with benzodiazepines. And as Dr. Horowitz said, even with the Ashton Manual, that the tapering is done in a curve, that you can taper a little bit faster in the beginning, but as you get to lower dosages, you go by percentages. So just like an airplane, leveling off and pulling up the nose and coming in gently as possible. And of course, eventually you do have to land. Eventually there is that drop off and the wheels hit and bumps, and like we wish the pilot had been more gentle with it. But but that's how I like to think of it. But the problem with the drug company, the pharmaceutical companies and medical schools not teaching us, it kind of reminds me of the whole thing of the 9/11 terrorists. The red flag when they went to pilot school was these guys didn't want to learn. They don't want to learn anything about how to land a plane. Who would go to pilot school and learn how to fly an airliner, but not want to learn anything about landing? So it occurred to me one day, it's almost like medical terrorism. They send doctors out in the world and don't teach them how to land patients properly, how to get them off of medications. So the idea is like, you're just going to fly forever. You're going to stay on these medications indefinitely, which is of course good for the big pharma companies. There's never any plan for us ever coming off of any medication. And I used to ask drug reps that when in the beginning, I'd say, well, how long do we do this for? Because that's, like if you ask like an antidepressant, how long do I give this for? And the answer is, well, for a year and then reevaluate. And then what? Well, you're going to reevaluate. And then if they need it, keep giving it to them. And, there's never really a plan. The answer is either reevaluate every year or indefinitely. Indefinitely pretty much to them means forever. So so cold turkey, definitely not good. What happens if you quit a benzodiazepine cold turkey? Pretty much for anybody, even the person who was just binging and not taking it long term, of course, there's a risk of a life-threatening seizure. And this was something that happened. There was a doctor that I knew like during the time when pain management was a big thing and all the pill mills and pain clinics were out there. And a lot of people were taking opioids and taking a benzodiazepine with it. And, whether it was helping them in some way or they were taking it to potentiate the opioid feeling or whatever, for whatever reason they were doing it, there came a time when doctors were trying to get people off and they understood tapering with opioids. They're like, okay, well, you're taking whatever, 400 milligrams of morphine every month. Let's give you 380 milligrams now. And let's give you like 350 the next, and opioids conveniently do happen to, a lot of them do come in liquid form and smaller dosages. So opioids kind of are designed, at least some of them are, that, like OxyContin, for example, comes in 80, 40, 60, what did I say, 80, 60, 40, 30, 20, 10, so there is like some tapering built in there. You don't really have that with a lot of other medications. But the benzos, like there was this doctor that I knew that thought he was very clever. He's like, I'm not going to give people benzos. I'm not going to get in trouble, and I'm not going to taper them. I'm just going to cut them off. If they want to come get opioids from me, I'm going to taper them off the opioid, but the benzo is going to be cold turkey. And his solution was, I don't want anyone to have a seizure, so I'm going to offer them anti-seizure medication. And I can't remember which one he had come up with. He sent it to me. He was really proud of his discovery that he found the perfect anti-seizure medication. And that was his solution. Cut his patients off cold turkey. And if you don't want to have a seizure, take this. And that, I hate to think of like what happened from that. At that point, I didn't really know what was going to happen. I had left the practice I worked for at the time, and we were just talking. And at that time, none of us really knew what to do. There was no talk of the Ashton Manual at that time or proper tapering, and so that was, probably if this guy, he might have either referred people to someone who knew how to taper patients, or maybe he would have, looking at the Ashton Manual, said, "Oh, look, I can switch them to Valium and give them 2 milligram tablets." And, there is a tapering process, just like with the opioids. So of course, if, cutting somebody off cold turkey or very fast does lead to serious problems. Like a person could develop protracted withdrawal for many years. They could develop akathasia. And that's one of the most terrifying things when I talk to people. Not only do I tell them, don't go to an addiction detox or rehab, don't go off cold turkey. Also, don't taper too quickly. If you try to taper too quickly, you're probably increasing your risk of developing akathasia, which could be a long-term issue. And as akathasia is a movement disorder where you can't sit still, and you see there's videos of people walking in the room, around the room, shaking their arms, and it's terrifying to even watch. And it's a terrible thing that, if and I know there's different levels of it. There's not just one severity level of akathasia, and it can be very severe, and people can develop maybe intermittent or milder forms of it. And it's the best thing is if a person starts to feel that way, they start to feel that inner restlessness, and that they can't sit still, and that maybe they are tapering too quickly, and that could be a warning sign. Slow it down a little bit. I'd mentioned the thing about the people who may have there are very few people who are addicted. Like they say on the Benzodiazepine Information Coalition, I think it says 0.2% of people who take benzos, that's the rate of addiction. That's what they used to say about opioids, but it wasn't true. That was what Purdue used to say, like 0.001 people will become addicted, and it probably was closer to 10 to 15% for the opioids. But for the benzodiazepines, it's almost unheard of. I had one patient, I had mentioned this in another, in an interview, that this one guy, he came to me one day, he said, I'm addicted to Xanax. Every time you give me a prescription, I take it all in one day. And then I go to another doctor and get another prescription. And he's like, fortunately I was able to get off of it, but please never give me another prescription. It never occurred to me at the time to ask him, like, how did you get off of it? Did you have any long-term problems? But maybe he had been binging, and maybe it wasn't a long-term thing, or he's probably maybe one of the lucky people that didn't get long-term problems, because not everybody gets protracted withdrawal or even very severe acute withdrawal. As far as dependence versus addiction, benzodiazepine dependence is not addiction. It's critically important to reinforce that. And there are different drugs. There's drugs that only have physical dependence. Beta blockers, the blood pressure pills, they cause physical dependence, and that's clearly a physical dependence. It's not a brain-related physical dependence. So if you stop taking a beta blocker, your blood pressure and your heart rate go up. Also, of course, antidepressants, benzodiazepines. Nobody is taking Prozac addictively. There's no reward to it. There's no pleasure associated with it. It's not an addictive medication. But there is a physical dependence. People do get severe withdrawal symptoms when they stop taking those medications. And then there's drugs that are addictive but have no physical dependence, like cocaine and methamphetamine, highly addictive. And it's not pleasant to quit them. They're probably, you might call it a withdrawal. People feel depressed and down and they wish they could take more, but it's not really a physical dependence. It's considered to be just an addiction or a psychological dependence. And then there's drugs that, and this is where the confusion I think comes in, that cause both addiction and physical dependence. There's the opioids and alcohol, both cause both addiction and physical dependence. And I think because of the fact that benzodiazepines are sedating and intoxicating, especially if a person takes too much, it's understandable that people might confuse them with opioids and alcohol. That that if opioids are clearly addicting, alcohol is addicting, why not benzodiazepines? But they have in common, opioids, alcohol, and benzos are all physically depending, cause physical dependence, but opioids and alcohol also cause actual addiction. So as far as the tapering, what I had mentioned, the unified tapering theory, why is it that people get cold turkey detoxed off of alcohol? Because, we can't just send someone home and say, okay, drink 10 beers a day, let's cut it down to 8 tomorrow, and in a week we'll cut it down to 6 beers a day. It wouldn't work, because once the person drinks, they have a compulsive urge to keep drinking. They can't really help themselves. And so there is a tapering process with alcohol. It's not as widely known, but it's called pharmacological extinction, or the Sinclair method. And this is a great thing about kind of being open-minded and working in addiction and helping people with physical dependence, that you can see all these different things and bring them together. That the Sinclair method is a tapering process for alcohol. The person takes Naltrexone, 50 milligram tablets 1 hour before they drink, and the compulsion isn't there. At least it's not as bad, and the cravings or obsession is not as bad. And a person is actually able to taper. And the taper with the Sinclair method can last up to 6 months, or it could last 1 to 3 years, kind of similar to benzodiazepines. So it is possible to do a slow taper with alcohol with that kind of medication-assisted treatment. And people have had great success. And they also don't have what they call the alcohol deprivation syndrome, where, when a person goes cold turkey off of alcohol, they might do great for a few months, and then suddenly they get what they call the alcohol deprivation syndrome. It suddenly hits them that they get severe cravings or obsession over alcohol. And a lot of people go back to it. And so alcohol can be tapered off of. Opioids also. That's what buprenorphine or Suboxone is. It's a way of, let's switch you to an opioid that doesn't cause addiction. It just causes physical dependence. And people taper off. And the recommended time for tapering is between 1 year and as long as it takes, and a lot of times 3 years or so, 1, 2, 3 years. I don't keep people on buprenorphine forever. I always talk about tapering. Not everybody wants to taper, so it's important to bring it up. And that's what I kind of see as harm reduction with the benzodiazepines. Even if a doctor doesn't start the tapering, it's a conversation that should be had at every visit. If the patient says, no, I'm fine, I want to keep taking my Valium, Xanax, Ativan, or Klonopin every day, I'm not going to taper. I only take 0.5 milligrams of Ativan every night because it helps me sleep. At least bring it up. Say, these things are toxic. This could cause severe problems for you later on. The faster you consider tapering, the better. The tapering process could take a long time. We can do it so gradually you won't even notice it going away. These are conversations that doctors could have as a form of harm reduction. So tapering, is not just for benzodiazepines and antidepressants. And just because someone is addicted to something doesn't mean that they shouldn't somehow be tapered if it is possible to taper them. Now, as far as naltrexone, I mentioned that with alcohol treatment, it's also used for opiate addiction. There's low-dose naltrexone. That was something that I thought might be promising for helping some people in benzodiazepine withdrawal. LDN is what they call it. And, where naltrexone is 50 milligrams is the normal dose for people quitting alcohol or opioids. LDN or low-dose naltrexone is in the range of 0.5 milligrams to 4 to 6 milligrams. And so it seems like, how could that possibly cause any side effects? But I haven't really seen a lot of promise with it. It is used for treating various pain syndromes like autoimmune issues like fibromyalgia. But I have prescribed it to some people. It'd be interesting to hear if there's any good results, because so far it either did nothing or it made a person more irritable or anxious, and I stopped it right away. I'm like, let's not go any further. It doesn't seem to be helping. Now this one, when I mentioned speculative treatments that I'm definitely not recommending to anyone, the question of, there's doctors that prescribe Suboxone or buprenorphine for opiate addiction, and they're like, wow, it works so well for opioids. Why don't we just use it for everything? Could it help for benzodiazepine dependence or addiction? Not addiction, sorry. I just did. It is a pain medication. It is an opioid. It's a form of, it's a very unique, unusual opioid. It's an antagonist and agonist, partial agonist at the same time. When benzodiazepine withdrawal, when protracted withdrawal or acute withdrawal becomes a severe pain syndrome, when someone goes to the hospital and they're like, I'm in such bad pain, I can't stand to live another second. I don't know what to do about this pain, whether it's pelvic pain, headache pain. And the doctor says, well, I can't find your pain because I can't find it on an MRI or a CT scan. Should they treat the patient with opioids? Well, buprenorphine does work for pain, and it doesn't cause addiction generally. It doesn't seem to, definitely not anywhere in the rate of, I don't think it does really, but it does cause dependence. I did have one patient where we got to that point where it was severe pain, and we were in a hopeless situation. And what are we going to do about the pain? And we tried buprenorphine for a day at a very low dose, relatively low dose, 0.5 milligrams. And this is something I think may be worth future study by some real scientists or researchers. The patient had 1 day of a complete remission of symptoms. And this is someone who is probably still in severe protracted withdrawal after a very long time, after being tapered far too quickly. And it was almost miraculous. And unfortunately, it didn't last the next day. Even 1 day later, the tolerance level jumped up dramatically. And buprenorphine has a ceiling effect, unlike other opioids, giving over like 32 milligrams. Anything more than that, the receptors are all saturated, and it doesn't work any better. So, but it was interesting to see that for whatever reason, and naltrexone and buprenorphine are both opioid blockers. Buprenorphine happens to be a partial agonist and an antagonist or a blocker. And for whatever reason, this particular one single person had 1 day of complete remission from severe protracted withdrawal from benzodiazepines. So yeah, definitely probably don't even bring it up to your doctor. But if you're friends with a scientist or a researcher, maybe like at Stanford or some major research center, maybe bring it up to them. And I did on my podcast. I put this one on the Benzodiazepine podcast. I did get to interview, I think a Dr. Ashton Jones. I think I don't want to say his name wrong. I had it in my notes somewhere, but a doctor who's the lead brain researcher at Rutgers University. And I put it what his interview was supposed to be about treating addiction with a class of sleeping medications called the orexin antagonist, which I think Balsamra is as an example. There's like 3 of them out, and apparently they might have some use in treating addiction. And I mainly wanted to talk to him because I wanted to bring up bind or toxic encephalopathy, damage to the brain caused by benzos, and he didn't have a big opinion. He didn't really have an opinion on it. And it was interesting because in his huge lab of hundreds of researchers, he says, well, the brain is great at rebounding from damage. The brain is great at either healing or accommodating for damage, and microscopic damage we can't really see generally. We could look at a nerve cell. They can probably look at an animal nerve cell. There's creatures that have huge nerve cells they can look at really easily under the microscope, but you can't really take a living person and say, you could look at a nerve cell and say, look at demyelinated or whatever, but they can't really look at this damage, this toxic encephalopathy or bind and say, look, there's where the damage is. Look, those receptors aren't shaped properly anymore, and we need to wait for them to replenish. That's the theory, receptors downgrade, and we hope that they replenish and start working again properly. That might be an interesting parallel of type 2 diabetes, which is an issue of receptors not functioning properly, completely unrelated. But, that's why, with type 2 diabetics, we don't give insulin until we have to. We recommend exercise and activity and all these other things to hopefully improve that receptor resistance. So I don't know if there's any parallel there, but there are other conditions where receptors stop working and leading to a medical condition. So yeah, we talked about treating pain. Another topic I wrote about on my blog, again, this one, probably don't even bring it up to your doctor, but maybe it's out there because this isn't even in the medical field. There's an herbal drug, kratom, however you pronounce it. It's out there. People use it for chronic pain. Unfortunately, it can have tragic outcomes when used for opiate addiction. People that try to self-treat, and they don't want to see a doctor for buprenorphine, which is really the gold standard now and very effective, but they don't trust doctors, which is understandable. So kratom is an herbal drug that has opioid-like effects. Unfortunately, for people with opiate addictions, it can stimulate cravings and lead them right back to fentanyl or heroin. And I have known people that either had life-threatening overdoses or died because they went that route of using kratom. But for a person who doesn't have an opiate addiction, here's an interesting herbal product that has opioid-like effects. I think there's different types, and different types have different balances of effects. And I'm definitely not recommending. I'm recommending against it. But again, maybe something to be looked at by researchers, and something that even the people that are proponents of it and even the people that sell it are arguing for more regulation in the industry. So, it can be taken more seriously in the medical field. Another thing that's come up, just to be thorough, flumazenil, the benzodiazepine antagonist, the thing that blocks the receptor and causes a person a person who's overdosed on benzos, you can reverse the overdose and probably cause a horrible precipitated withdrawal. But could it be used to treat protracted withdrawal? People have brought this up to me. They said, oh, there's doctors researching it. Specifically, if you're interested, the main doctor I heard about is Dr. George ONeill in Australia. He has an addiction clinic, but apparently he is experimenting with subcutaneous pumps and implants. And my idea was, well, if that works, why not a sublingual troche made by a compound pharmacy? And then my question was, well, you can't give flumazenil to a person still taking benzos during a taper. And I've heard people saying, well, no, if the dose is low enough, maybe you could, because you're not really saturating or blocking all the receptors, and maybe there's some beneficial effect. Again, don't go to your doctor asking for flumazenil, especially if you're still taking benzodiazepines, and they're not going to give it to you anyway, but they'll probably say, like, who'd you hear that from? And, but again, something worth looking into, and maybe looking up the studies and who's using it and how are they using it. So definitely something interesting and worth looking into. But I wonder if that would be a possible way to implement it, if there was research and a way to, a standard dosing like this is how much it can give safely, that might help a person. And then maybe a compound pharmacy could make a sublingual version of it. I don't know, maybe it's something I should call the compound pharmacist, which I'll bring up in a minute, ask them about. Maybe they know something more about that. Compound pharmacies are an important thing. I had a guest on the Benzodiazepine Podcast, Laura Delano. She's the founder of the Inner Compass Initiative, which is, I think, a curated forum. It's another place that people can go and learn about tapering. Tapering, if you don't want to taper with your doctor, you can't, and you don't want to use expensive compound pharmacy medications. And there's ways to, which I won't go into, but it's all this information is out there of crushing tablets and weighing them on scales. You can weigh milligrams, and making liquid forms of the medications. And one thing I'd be concerned about, one person brought up to me that they were shaving off parts of their tablet, shaving the tablet and then weighing it. And the problem with that is that the medication may not be evenly distributed through the tablet. So, and maybe these communities that talk about that go into more detail, but I think you'd have to crush the tablet thoroughly and make sure it's mixed up thoroughly, and then weigh whatever portion of it. But that's out there, and I'm not recommending it, but that's information that's out there. But anyway, part of the conversation I had with Laura Delano is that I mentioned compound pharmacies, and I said we really could use a lot more of these out there, especially ones that know how to help doctors with tapering people off of benzodiazepines. And she responded, well, that's almost all we need. That's the main thing that we need, and actually it's already out there, because I was imagining, like, there's this guy locally in Miami, Steve. It seems like all the great pharmacists are named Steve somehow. But anyway, so Steve, the pharmacist, had a compound pharmacy and was very good at helping me manage tapering people. I actually met him through a patient, and he helps to set up the schedule. And if you say, like, you could say, I want to taper the person from this to that in this period of time, assuming things go well, and he would set up all the calculations and everything ahead of time. Really great pharmacist. I think he went out of business, and I don't know why, but he transferred his records to a place called Premarin in North Carolina. And Premarin, they work with a bunch of different states. They weren't quite as good as Steve, but they've been great so far. Otherwise, I've had good conversations with them. I shouldn't say anything bad. They work in Florida and a list of several states, not all the states. But compound pharmacies can make liquid solutions of benzodiazepines. And while the Ashton Manual is great with convert people over to Valium, and the good thing about that is that your insurance would cover Valium, and it's affordable and it's inexpensive. And and the way it works, you're probably all aware of that. Valium is lower strength than all the other. It's a fraction of the strength of Xanax, lorazepam, alprazolam, lorazepam, and clonazepam. And so you switch the person over to the weaker, longer lasting one. Valium also lasts a very long time, has a long half-life, so you don't get the interdose withdrawal symptoms you might get with other ones. And it works great. But you could also take the benzodiazepine the person's taking that they're comfortable with, like clonazepam. You could say, you're taking a 0.5 milligram tablet every day. Let's make it 0.5 milligrams per 1 milliliter. And now you use an oral syringe, and you can reduce by steps by tenths of a milliliter, or even 200ths of a milliliter at a step. And you can do it very gradually. And then as you go down, you can reformulate it. Say you get to 0.25, now you make the new formula 0.25 milligram per 1 milliliter. And now if you go those same steps, now you're going slower. So you're following hopefully something like that curve that airplane landing curve, or that hyperbolic curve described by Dr. Horowitz. And so, that's a great tapering method that a compound pharmacist can be a partner in if they know how to do that. And there's another one when I get to it in my notes I'll mention, other than Pyramid. There's a great one. Well, I've heard they're great. I haven't worked with them yet, but there's one in Texas that somebody highly recommended that I believe they actually work with every state, or at least all the continental US states. Okay, so we talked about the Ashton method a little bit. Oh, yeah, here it is. Pharmacy Solutions in Arlington, Texas, rxcompound.com. And I didn't write it in my notes, but I remember the guy's name was Nick Miller. I was told to ask for him. He's the PharmD, the pharmacist that is apparently very knowledgeable and has worked with very closely with doctors that are well known in the benzodiazepine tapering industry, which is not very big, but they're, he's worked with the doctors. Apparently they have all kinds of certifications that other pharmacies don't have. So yeah, one patient highly recommended that I reach out and speak to him, which I'm planning on. Maybe he'll even do a podcast interview. Let me know if we're running out of time. I thought it was going to take me a lot. I thought I was going to go through this a lot faster. So yeah, otherwise on the podcast, I had interviewed Chris Page. He's actually on there twice, speaking about akathasia. He founded the Institute for Akathasia Research and Prevention, which is a great idea, funding research for researching akathasia, finding what might help. And of course, it was a great event. There was great music, great food. We learned more about Chris's experience and about the, kind of the people that showed up to the event, learned a lot about akathasia, it's an unusual word that a lot of people have not heard about before, but we learned that it's a thing that feels like maybe like you stuck your finger in an electrical socket and it just stayed there for years at a time. And he was suicidal for like 3 years straight. People feel like they want to claw their skin off and crawl out. It's just a horrible thing. And he was talking about also developing a staging system for staging, different levels of akathasia, which is interesting. And a drug he had mentioned, again, don't ask your doctor, it's not really being used at all, but pentoxifylline, which is a medication used for blood flow with peripheral artery disease, also been used for PTSD and other cognitive dysfunctions. So he talked about possibly research being done for that. And if you look at the Benzodiazepine podcast, of course, Nicole Lamberson was on it. That was an incredible discussion. We talked about Phenergan being useful for some people, getting some temporary relief from protracted withdrawal symptoms. And very quickly on the YouTube version of that lecture, that interview, somebody commented quickly and pointed out, Phenergan can also cause akathasia. So, of course, don't take advice from a podcast or a YouTube video on medical treatment. Ask your doctor, and then ask your doctor to read that package insert, the prescribing information very thoroughly, and don't discount the rare side effects. So there's no one size fits all solution. That was actually the tagline for my Rehab podcast. So it still applies for benzodiazepine and bind. Everybody's different. Anybody can have any kind of reaction to a medication or a different experience. What works for 100 different people might cause a reaction in one person. People should, if a doctor prescribes a supplement or a medication, be very careful. Start low. If a supplement is available in different strains, try the lowest one, or be very careful. Maybe ask more questions. Ask people in the community. What kind of the doctor says try magnesium. Well, what kind of magnesium? There's a bunch of different kinds. And just because everyone says this is the one to take doesn't mean it's going to be the one for one particular person. Another thing that Nicole and I discussed was ketogenic dieting. Are there studies to support it? Probably not. There's some mention of it on some doctors' websites and stuff like that, but it makes sense because a ketogenic diet where you eat very low carb and go into ketosis, your brain is surviving on ketones rather than sugars, and it does tend to lower irritability and excitability of the central nervous system. They actually use ketogenic diets for medication-resistant epilepsy or seizure disorders in children. So it kind of makes sense. If nothing else is working, why not maybe try it? Although it did come up, would a keto diet help with histamine intolerance? And one issue is that a lot of the foods that you might eat on a keto diet are rich in histamine, so you have to be careful with that. Probably work with a knowledgeable dietitian, nutritionist. If especially keto diets are not that easy. They're not always that straightforward. So you have to think about things like constipation caused by the diet. With a histamine sensitivity, I just want to mention the enzyme DAO can be helpful in digesting foods. If you're not aware of it, you can take it before meals. There's one I found on Amazon, that Nature DAO, that I liked. It's on one of my blog posts at the top. Ketamine, I was hopeful about ketamine. I haven't really heard any great results. No one has told me yet. I did ketamine infusions and it helped me a lot. I've prescribed low dose ketamine troches to some people, and either they didn't help, or at least one person I can think of, it made them feel worse and more anxious. So I kind of just gave up on it, but it does make sense. The way ketamine works on NDMA, glutamate, GABA, it kind of all fits in that it should work, and it should make sense. Maybe if a particular person were to do a full series of 6 infusions and go through the whole process, maybe it'd be interesting to get some feedback on if it has helped anybody. Because I have seen ketamine doctors out there on a forum say, oh yeah, it works great for benzodiazepine tapering and withdrawal. And I don't know if it does, or if they're just saying it works for everything. It does also have an anti-inflammatory effect on the brain. It promotes neurogenesis, forming new dendritic connections in the brain. So ketamine makes sense on paper, but another one that came up on the podcast, this episode has gone offline. You won't find this episode on my podcast anymore, but I took it down because somebody complained a lot. It was an interview I did with the owner of a Mexican stem cell clinic. And you may be aware of this clinic. They have an online presence. And excuse me. And the interview was great. It was very interesting. I learned a lot about stem cells, and it seemed like maybe an idea for someone who's at the end of the rope. Nothing else is working. They're just basically, they've given up and they don't want to try. They've tried everything in the world. Nothing has worked. What about stem cells? I don't know. I'm not recommending it. Probably don't try it. Don't go to Mexico and get stem cells. I always think with these things, would I do it myself? And when the guy was talking, when I was interviewing him, I was thinking like, wow, this is affordable. It's great. It's effective. I want to do this just to feel better and younger. And then as I thought more about it, I'm like, well, I don't know if I really, there's some negatives in there that even in our interview came out. And so, yeah, I'm not recommending it, but it's important that things are discussed and that they're out there. Binaural beats, binaural beat programs, these sound programs that can relax you and put you in a state of a delta wave state. You can find them on YouTube. There's a company I like, Sacred Acoustics. The CEO founder, Karen Newell, is on the podcast. They work really well. I've had patients who are in benzodiazepine withdrawal, either acute or protracted, and it's helped multiple patients of mine get better sleep. People that were only getting like a few hours intermittently were able to sleep through the night. And the program that they have that I really like is called Whole Delta. They sell it for like $15, but you can find these things on YouTube and other places for free. I even make my own. If you're into music production, it's possible to make your own. And if you don't want to wear headphones, because binaural beats requires headphones because it's different frequencies in each ear, you can play them over the air over your TV or a speaker, because they do. Then they call it isochronic beats, which is over a speaker, and it still works. It's really the important thing is the tones slowing down over time. As far as falling asleep, I just wanted to throw in, somebody had brought up to me that we had discussed L-theanine as a supplement. It could cause a bad reaction. I haven't heard of any bad reactions with it, but be careful with any supplement. Start low and be careful. But L-theanine has helped people get better sleep. I actually had a patient today report to me that her regular acupuncture gave her a reaction. She had a bad reaction to acupuncture. Didn't happen until the next day. And she's been doing it regularly, but now she's tapering off of a benzodiazepine. And so just to point out, anything can happen to anybody. Anything can cause a reaction, not even just medications. I mean, it's possible maybe even listening to those binaural beat programs, even though it's just music and sound, maybe could cause somebody to have more anxiety. something that I have not seen a lot of negative reactions from, which is interesting if it's legal in your state, CBD, medical cannabis. I've had multiple patients that have gotten better sleep and had less anxiety with tapering. Definitely not recommending it. I've for a long time was anti-cannabis, especially for young people under 25. But if nothing else is helping, or if you're taking it anyway, and you already have like gummies or edibles, and you're like, oh, doctor, should I stop taking these edibles? I'm in protracted withdrawal and nothing else helps me. But if I take a quarter gummy, I can get a little bit of sleep. Well, why not? It seems to be less toxic than a lot of the FDA approved benzodiazepines and psychotropic drugs. Yeah, tell me if I have to stop. I'm going to skip over a couple of things. Avoid going in the psych ward if possible. I mean, if it's absolutely necessary, stay out of the psych wards because they kill people. They take people off medications cold turkey when they shouldn't. They switch people's medications. They take people that, maybe they've gone in for a suicide attempt, and then they won't let them out until they take a drug that has suicide as a side effect. You can't leave the psych ward until you take an antidepressant. So, if someone has to go, if they're really in danger of hurting themselves or whatever, but if you don't have to go, be careful. Don't go to the ER. And then, like saying you want to kill yourself in the ER is like saying you have a bomb on a plane, like a whole, bunch of things happens very quickly. The police are there and suddenly you're being carted off to the psych ward for at least a few days. And it either takes a good lawyer or at least taking a few doses of an antidepressant to get out. And sometimes you can't get out. Sometimes they just want to keep you. And a lot of these psych drugs have black box warnings about suicide now. And the benzodiazepines as of 2020 have black box warnings that were not there. So doctors that have not looked at the literature about benzos for a long time that thought back from the 90s, like these things are so safe. They're not that safe. And things have changed. The literature has been updated. It doesn't stay the same forever. Another medication. I don't know anybody that's tried this. I found one guy online that said it was prescribed to him, but he didn't want to be a guinea pig, which I understand. But it's worth further research by the scientists. Acamprosate, which is known, but Campro is the brand name. But it just everything like ketamine again. Everything seems to make sense on paper. NMDA receptor antagonist enhances GABA-A receptor activity. Works differently from the benzos, so there's a very low likelihood of causing dependence. It helps with alcohol withdrawal for lowering kind of smoothing out the neurological signaling or something like that. With it kind of calms down the person going through alcohol withdrawal, which is not all that different from benzo withdrawal. And there's also mention of it helping to control tinnitus or tinnitus, however you want to pronounce it, hyperacusis, ear pain, inner ear pressure caused by spasms of the tensor tympani muscle. So there's a lot of things in the description of acamprosate that all seem to make sense, but I don't know anybody that's tried it. But maybe it would help, maybe not. It's something to be looked into. Safe and sound protocol, talking about the middle ear, is a sound therapy. Chris Page, again, was on the podcast twice. He's a provider of that if you want more information on safe and sound. It helps with the vagus nerve polyvagal theory, which was developed by Stephen Porges, the scientist who developed safe and sound protocol. There's electrical devices out there that claim to stimulate the vagus nerve. I think I saw a comment pop up. I haven't really been watching them, but I haven't heard really any good feedback on if these devices help at all. They don't seem like a great idea. These electrical devices that you wear on your wrist or your ear that supposedly stimulate the vagus nerve. There's actually scientists at Stanford that are doing surgery and connecting electrical stimulators directly to the vagus nerve for depression. And I'm not recommending that either. That's major surgery that you probably don't need or want. And they say when they turn the thing up high enough that people start choking from it. Sorry, I'm going to finish now. Let me just see if there's anything critical. If you like gardening, I recommend gardening. Start a little private garden in your backyard, a little sanctuary. I have a patient that loves that. She does gardening, and her family invaded her garden. They started messing with it. I'm like, of all things, the one thing that's helping you get through your taper is your gardening, and they went out and messed with your garden. Why would they do that? And now they've learned better. They leave her garden alone. Meditative practices, mindfulness. A garden is a great idea. It kind of distracts you when you're growing plants and working with your garden and keeping it in. I think it's a great idea. It also gets you outside in the fresh air and sunshine. Okay, yeah, I skipped over a few things. And as far as bringing new doctors into I had written a blog post about that. Direct primary care is an affordable way that doctors are getting into helping people directly. They have subscription programs. I don't do that in my practice, but if you look up direct primary care, a lot of doctors are getting into that, quitting their jobs at hospitals and big clinics and offering affordable subscriptions for individuals and families. If those doctors would learn about how to work with compound pharmacies and how to treat bind, that would be a great opportunity. And those doctors may be looking for how can they treat more patients and find more patients. And I feel like direct primary care would be a good connection to make. And it's important to reach out to doctors in different communities where doctors are and say, like, what do you think about? And I've been talking to doctors I know saying, go give a talk. Maybe you don't know anything, but maybe you can learn about it. Go to the community to learn more about bind and, get involved and interact with people. And maybe you'll want to get involved in providing treatment, and then we'll have more doctors. Anyway, sorry to take up so much time. Thank you.
Thank you so much. I want to speak on behalf of all of Benzo Warrior Community. I want to thank you for listening in the community, because I know you have. I want to thank you for the podcast that you do, which has been so good. I've learned a lot from it. Thank you for the open-mindedness, and we really appreciate you being here tonight.
Oh, thank you. Thank you.